this afternoon we're certainly fortunate to have a distinguished speaker in our midst. Dr. Linda Chambers is going to present to us all an approach to the transfusion of blood and blood products that Ohio Health has now adopted. Dr. Chambers was the individual that sort of spearheaded this whole thing, and this has been well researched and vetted and just taken apart, dissected, and it certainly is a ponderous effort on her part, and one that I think is certainly appreciated by Ohio Health. Dr. Chambers is a pathologist at Grant, and her specialty area is blood transfusion and transfusion of blood products. We all have our own sort of, we've all used these certainly use blood, and we probably a time or two used all of the blood products that she will address today. And when we began to use them, we used them according to what our culture dictated rather than with any particular evidence base. And we often got mad, or mad as hell, pardon my French, if anybody, especially from the blood bank, would question what we were doing. And but over time we've seen that when we adopt an evidence-based approach, when we have a system-based approach, things tend to work out a lot better. And this system is adopted by the entirety of Ohio Health now. And the system certainly works, and it'll allow us now to have some guidelines when we use blood, when we use all of these blood products. And we certainly do appreciate that. Deep down, I think we all know that if there's we want to do the right thing for our patients, and we want to keep them as our main focus, and try to, as best we can, shed all of the bonds that we have from our culture. Now, in that light, I think Dr. Chambers will speak to that today. When I looked over her CV, I was certainly humbled, to say the least. She has impressive credentials. The papers that she's published are just enormous, and the sections of books and the articles are just overwhelming, especially to a person whose last attempt to have anything published was summarily rejected by my high school newspaper. So as I said, I was humbled. She had appointments to Harvard and to Georgetown, OSU, and Children's Hospital, and someplace called California that I really hadn't heard of or spent a lot of time in. We're certainly honored to have her in our midst, and I present Dr. Chambers in that light.
Thank you. Thank you very much. That was lovely. Well, before we get started talking about transfusion, I thought I would tell you about a talk that I went to probably 10, 12 years ago now, where they had the speaker, who's a woman, pretty well wired up like I am here. They were videotaping, and they had some remote listeners, and then they had the microphone for the room that everybody was in. And she ended up with so many things attached to her skirt that as she talked, her skirt kept going down and down and down. And she was sort of standing over at the side like this. At one point, she just sort of went like this, and she kept talking, bent down, pulled her skirt up. It was the funniest thing I've ever seen. Anyway, so since then, anytime I go and there's more than one piece of apparatus that you got to do for the talk, I'm glad that I'm not wearing a skirt. Anyway, well, hello and welcome. I'm hoping we can talk through today a number of things about blood transfusion that I think will be new to you. that are very much at play in the thinking of the experts that publish now about how to use blood transfusion as a therapy. And I hope I can give you a sense of what some of that content is and the timeline over which it's unfolded and what it means for us now when we look at a task such as developing some transfusion guidelines for the Ohio Health Hospitals. So the first thing I want to do is I want to give you an overview of the current risks of blood transfusion. When you ask a patient, they want to know about AIDS, and then they want to know about HIV, and then they might know something about hepatitis from transfusion. But in their mind, the risks of blood transfusion are primarily infectious. Well, they aren't. Let's go through them. You'll see on these tables that there's descriptions over on the left-hand side, high, moderate, low. Those numbers come from a protocol that was developed at NIH to be used when they did informed consent for investigational therapies. So they put risks into categories that were factors of 10 different. So for example, greater than 1 in 100, and then 1 in 1,000 to 1 in 100, 1 in 10,000 to 1 in 1,000. Attached a word to those, and then depending on where the risk fell in the hierarchy, the protocol defined whether or not it was a topic that had to be disclosed in the informed consent. So doing this for blood, and these approximate estimates are all pulled out of the literature. In the high category, things that really happen with some frequency, CMV transmission, even with highly leukoreduced blood, formation of red cell antibodies. We hardly even consider that a transfusion complication, but it is, and in the right settings, it actually can have major medical implications for the patient. Immune suppression, and formation of HLA antibodies. And now all of these are innocuous in most patients. We know what to do with antibodies. CMV, usually it's a subclinical infection, unless it goes to someone who's profoundly immunosuppressed and happens to have no immunity to CMV, is it a problem? Formation of HLA antibodies, unless you're going to get a solid organ transplant, who cares for the most part? So the things that happen with a high frequency with blood transfusion are not very scary. Moderate are things like fever chill reactions, iron overload. You can scan them. But again, in the moderate category, 1 in 1,000 to 1 in 100 frequency, there's not much, again, that's very concerning. We're certainly not seeing HIV yet. We have to get down in the range of 1 in 10,000 to 1 in 1,000 before you start to see transfusion reactions. And the ones that occur with some frequency are allergic reactions, transfusion-related acute lung injury, and delayed hemolytic transfusion reactions. Continuing in the very low category, acute hemolytic reactions, minimal are some things that are starting to look concerning. Septic reactions, fatal transfusion-related acute lung injury, hemolysis from incompatible plasma, and all the rest are in a category called negligible. Now, meaning at NIH, if they were following their protocol, they would never even talk with a transfusion recipient about HIV or hepatitis C or the possibility of having a fatal hemolytic reaction from a mistransfusion. I want to go back to the high category and explore this seemingly innocuous category of immune suppression and then expand on it a little bit. Because if you just do the exercise that we did now, you might walk away thinking, blood's pretty darn safe. We took care of all the infections. The thing that causes death the most in the United States is something I never even heard of, this transfusion-related acute lung injury. So what's the big deal? Can't we go to 1030? I mean, we really want to transfuse blood, and for 20 years we've been holding back, and now the blood is so safe. Can't we just go for it? Well, let's look at immune suppression. We've known for a long, long time that blood is immune suppressive. In fact, before there was cyclosporin for immune suppression after kidney transplant, it was the practice to deliberately transfuse the intended recipient, the kidney recipient, ahead of time, and that was associated with better graft survival for the same degree of matching. And what the clinicians were capitalizing on was the sort of general immune suppression of transfusion. When I was a fellow, we used to argue about whether that transfusion had to be from the donor of the kidney, so it was sort of a specific anergy that you were trying to establish, or whether any old blood product could be used. And most people felt it had to be a donor-specific transfusion that was somehow inducing a specific, very, very fine, pointed tolerance in the recipient that would then come into play in the survival of the kidney afterwards. Well,